And this is why I'm so glad that Dan has agreed to be our keynote speaker for this meeting. I'm going to set a precedent here. Introductions are going to be very quick, and we're not going to brag about everybody's super accomplishments. But Dan started from Oxford, went to Cambridge, and is in Newcastle for years, and now has a new position also in Paris at the CNRS, which I'd like to hear about. It wasn't easy to find all about it, Dan. But his special contribution is what?
It's a state secret.
Is it now?
Yeah.
And state-funded, too. But the marvelous thing, I mean, he's on my list of Google Scholars. Send me everything he publishes immediately. Because for me, he's a model of creativity combined with critical thinking. And when he does his critical thinking, he doesn't just say, you're stupid. He has this marvelous ability to say, what is it you really mean? And are you sure you mean that? And it's just this, I call it constructive engagement, where you really, really try to understand what the person's saying. And this is another goal I have for this meeting. I mean, I find evolutionary psychiatry confusing. I read people's papers, I try to review them, and it's really hard for me to figure out what the heck is this person saying. And guess what? Other people read my papers, and they think the same thing. So if we can possibly come out of this meeting with any ways of making that process a little bit simpler, that would be good. I'll stop here and turn it over to you, Dan, to talk about depression.
Thank you very much, Randy, for that very kind introduction. And actually, I hope that this will be about constructive engagement. I haven't really got a clear central argument I want to make to you, but I just want to think about how evolutionary thinking can help us understand this very prevalent problem of depression. So I have two linked missions today. The first is really about depression, and the second is a bit about evolution. And the first is to ask this question, which is hardly a new question, and I'm hardly the only person to ask it, of course. Is depression best viewed as a brain disorder? And I'll talk about why we might ever have come to view it that way and what people currently think about it a little. And if not, of course, what are the alternatives? How could we view this prevalent and distressing set of experiences? And secondly, how does evolution help us think about this problem? Because it's a hard problem. Does it affect the kinds of answers that we might propose to that? And does it help us perhaps, as Paul has already suggested, give us a kind of integrative way of understanding why different people come to different answers about question one, and how, in fact, they could all, in a sense, be right. I think, just to sort of already give away the punchline, you can view depression as a brain disorder if you like, because brains are involved, and it causes a lot of suffering. So, you know, those would be prima facie reasons for framing it that way. But if you do so, or as Randy says, do so monomaniacally or exclusively, you're going to cause yourself a lot of problems, effectively. You're taking a particular lens that you might have for looking at things and trying to kind of subsume a very complex experiential problem, very individual problem, under one particular kind of tool. And then that's going to cause you a whole lot of difficulties with how you look at it, and then generate, for every kind of nuts idea that gets over-applied in psychiatry, it generates an anti-movement, right? An anti-Freudian movement, an anti-behaviorist movement, an anti-psychiatry movement, an anti-biological movement, a pro-biological movement, and so on, right? Because if you over-apply an idea in one direction, something pops up at the other extreme to say you're missing out this other thing. So does evolution help us to think about that? For me, a very formative kind of period is around the time of Nancy Andreasen's book, The Broken Brain, The Biological Revolution in Psychiatry. So, perhaps if we want to talk about ideas getting somewhat oversold in psychiatry, here's a great example. This was back when I was a graduate student, actually a little before this particular book. And this was a period in the late 20th century of this tremendous selling. We've had all of these years of people suffering and not really having effective medicine to deal with it, but neuroscience is going to sort us out, right? Brain imaging, coupled with the new pharmacotherapies that were becoming available at this time, is just going to change all this, right? And it was really a very big bid for our attention. This is not the only book, but it was a particularly interesting one. Now, we're 50 years on from this moment. Has the promise of that been made good? I'm going to argue in various ways that it's not. But I think people were sincerely selling a vision that they had at the time. So the thesis kind of underlying The Broken Brain and other similar books is that depression is most usefully viewed as a brain disorder. And we can question that in two ways. Firstly, if we want to view this as a disorder, as a dysfunction, is it in the brain that we should be locating it? Right? So I think that's actually questionable at this point, or primarily in the brain, or exclusively in the brain. And secondly, should we be viewing it as a disorder? Right? And so both of those questions, I think, are still in play 50 years on from this moment, where a very clear bid was made in this book to say, look, all of this stuff about the unconscious and about social problems and so on is kind of epiphenomenal, and what matters is people's brains are working differently, and we can, once we understand that, fix it with drugs particularly. Okay. So when you come to frame something in medicine, it's really important to think about the implicatures. So the idea of implicature goes back to the philosopher Paul Grice. It's the things that you're going to understand from what I say that are not literally in the words, right? They are defeasible, as he put it. So I can say things like, I can say depression is a brain disorder, but I don't mean that the brain is the only bodily system involved. I can say that, right? But if I don't say the second part, if I don't defeat the implicature, you're going to be saying, well, the fact he says it's a brain disorder means he kind of thinks that other things are not important. So people reliably infer from the things we do choose to tell them about that you're asserting that, in fact, other things are not important, or you would have said them. So when we say depression is to do with a broken brain, what are the implicatures of that? Well, firstly, something is broken. This is not about things fulfilling their regular functions. I'll come back to that. Secondly, that something, that which is broken, is inside the individual body. It's not in society, it's not in relationships, it's not in the broader ecology or the social network. It's inside people, individual people, people who turn up in psychiatrists' offices. And in particular, the thing that is broken is in the brain. It is in the brain you need to look, and it is at the brain level you need to intervene. Now, I think there are long currents in psychiatry to question all three of these things, and I think there must be individual cases in which each of these are true, but whether they're always true or generally true of psychiatric conditions, I think is still reasonable people can still dispute. How does the evolutionary approach help us to think about that? Well, firstly, the question of whether something is broken, due to Randy and George Williams' distinction between defenses, defense mechanisms, and dysfunctions, we can already say, well, something is happening, certainly something is different in the person who's having depressive experiences, but is it necessarily the case that some mechanism within them is broken in the manner in which the heart is undoubtedly broken in heart failure? Okay, so there are cases, when your fibula breaks, you're pretty sure that it's broken, it's not fulfilling its evolved function. This is not true necessarily, or at least it's debatable for people with mild to moderate depression. So the evolutionary approach already gives us some sort of resources for challenging the idea that something is necessarily broken within the individual. I think it also gives us a different way of understanding the idea that thing, the broken thing, is within the individual body, because I'm going to talk a bit later about what I believe the evolutionary approach to imply or entail, but for me it has a very natural focus on the social and ecological determinants of what happens to us, right? It naturally causes our focus to think about the individual in its environment, in his or her environment, and the kinds of socio-ecological determinants there might be, which might lead us to the conclusion that the kinds of proximate causes we should be looking at are as much in the environment as in the individual body. And then finally, the evolutionary perspective, I'll argue, and this perhaps is a little novel today, helps us also dislodge the idea that the center of that brokenness, if there is any, is necessarily the brain. The brain is more important. As I'll argue, we have a tendency, I think, in the history of thinking about depression to over-focus on the cognitive symptoms, and there are some interesting reasons why we might do that. To think what's going on here is really purely a cognitive thing. But actually depression is also, as I'll argue, an immune condition. It's also a metabolic condition. It's a condition of the whole systems of the body and the way they're delivering energy to different kinds of tasks, biological tasks, in an ecological context. So perhaps it's quite natural to think, well, if this is primarily a cognitive disorder, it's the thoughts that people are having that are the problem. Therefore, what is the organ of thought? It's the brain. So this must be something in the brain, not forgetting that those thoughts are sitting on top of a whole load of metabolic and immune changes that go along with them. We'll say a little bit more about that later. Okay, so come back to the idea of the broken brain and Andreasen. 50 years on, is the brain the main locus of difference between people who are diagnosed with depressive disorders and people who are not? Neuroscience would certainly like you to believe that's the case. But actually the literature, I think the 50-year report card on that bold claim that, oh yes, it's the left amygdala that lights up more in depression, that's what's going on, it has to be, could do better, right? And I particularly draw your attention, I'm not an expert on this, I'm not a neuroscientist in any way, shape or form, but I draw your attention to this very challenging study in 2017. It's a meta-analysis of 50 years of functional neuroimaging of depression, in which they find huge numbers of studies that have made comparisons between people, a depressed group and a control group, for brain activity during some task, and unfortunately the task differs a lot from study to study. And basically what they find is that every study finds something. Every study finds a significant difference between the depressed and non-depressed group. That should already make you worried, right? Because with the modest statistical power of these studies, at least a quarter of them shouldn't find anything, but you never find any that find nothing, which already makes you worry about false positives. But most importantly, in a meta-analysis, they show that actually there's really no consistent story about where the differences are to be found. Part of that may be to do with the fact that each study uses different tasks. Some people are doing an emotional task, some people are doing cognitive task. In some cases, it's a resting state thing. But the point is there's actually no really clear picture. There are hundreds of locations in the brain have been identified by these studies as the locus of significant difference. And in some cases, it's hyperactivity in depression. In some cases, it's hypoactivity. There's a whole literature that's moved on to the idea, okay, it's not the individual places, it's the connectivity. Could be true. But there's really no very clear story about the ways in which brain activity are different in people who are currently experiencing depression and not. And this is important because people talk as if there were. You only have to read stories and psychiatric journalism and so on to say, well, we know that when people are depressed, their brains are working differently and their left amygdala is lighting up. We don't actually know that. Okay, we don't know that consistently of all depressed people versus all non-depressed people. And it's very important that we have some humility about actually the confusing state of the literature. Likewise, it's true, it's pretty reliable that there's lower hippocampal volume in patients with depression. A couple of things to say about that. Firstly, it seems to be a consequence of disease as much as a cause, in the sense that the longer people have been depressed, the bigger the effect size gets. And it may be part of the process that's consequent on having depression, that there's brain atrophy of various kinds, and also that the effect size is really small. A Cohen's d of about a fifth of a standard deviation. People would say that's really at the very bottom end of any real scientific interest. Of course, the kind of effect size you need to have depends on what kind of question you're asking, but nonetheless, by most consensual criteria, this will be a very small effect size. It's also not specific to depression. It seems to be specific to psychiatric illness in general. So, okay, brains might be a bit different between people who are having depression and people who are not. But actually, the effect sizes are small, and it's a bit of a mess. And it's odd that we focus on these so much, because there are some things we know are really different between people who are experiencing depression and people who are not. And one of the things we really know is different is the immune system. So this is a meta-analysis of inflammatory cytokines in depression, people with depression versus people without. And so inflammatory markers, so this is the innate immune system. It's the inflammatory response you have to various kinds of challenges, wounding, and so on. You produce this whole suite of pro- and anti-inflammatory cytokines that kind of control your body's inflammation response to those threats. And in this meta-analysis from a few years ago, they show that really consistently IL-1, IL-2, IL-3, IL-6, IL-7, IL-8, and so on are all increased in depression. And IL-4, which is an anti-inflammatory cytokine, is actually reduced. That's the effect you'd expect it to go if depression were a pro-inflammatory condition. And the point about these is that these effect sizes are close to a standard deviation. This is much bigger, right? You would never be able to diagnose someone as being depressed or having a history of depression or not from the size of their hippocampus, but you could do it actually pretty well by the state of their inflammatory markers, which is very, very interesting that we don't focus on this more. Perhaps there are psychiatrists in the room who can tell me why, why that doesn't seem to get more airtime in the discussion. Depression is not the only thing associated with increased inflammation, and that's interesting. But these are big effects or big differences. And so I think that's of interest. And related to that, by the way, there is also some data that shows that people with depressive symptoms are also hotter, right? Which is their body temperatures are hotter, both under the tongue thermometer and various kinds of sensors that they have worn, which makes sense, right? Because one of the things we know about inflammation is it does increase body temperature, and you spend metabolic energy in a particular way to raise the increase of your body. That's why you feel hot if you have an inflamed reaction to something. So these things are interesting, but they're really not prima facie anything to do with the brain. And so I don't know how, we have to think about how we integrate into our view of depression that this is a systemic change in individuals. They're allocating their energy in different ways, including to inflammatory activity. By the way, you can intervene in depression with anti-inflammatory drugs. Now again, people might say, well, this stuff about inflammation is not very important because the drugs don't work primarily at the level of the immune system. We're thinking about SSRIs and so on, they work in a different way. But actually, you can just give people ibuprofen for depression. And in meta-analyses, there is some clinical response. It's not huge, but it's meta-analyzed. And as I will show later, the clinical effectiveness of things like SSRIs is not huge either. And in fact, it's not clear that simple anti-inflammatories like ibuprofen or diclofenac are any less effective than for the acute treatment of depression than antidepressants. So someone here may have greater expertise than that than me, but just looking at the literature, that seems to be true. Depression is also associated with a number of other things, metabolic syndrome, which is things like insulin resistance, high body weight, cholesterol changes, and so on. I don't think we focused enough on what's going on that all of these other systems of the body would be so different. Okay, so let's just sort of sum up this little part so far. What tends to happen in depression, and I guess this is understandable, I'll just say a bit more about that, is that we're struck by the cognitive responses. People are ruminating. People are perseverating on all kinds of strange thoughts. And so we think, oh, well, that must be really what the core of this is. And there might be some epiphenomenal stuff, like they don't have energy to move around and, and so on. But really, this is the thing that we need to be focusing on. And we perhaps tend to spend less time thinking about, well, there's all this other stuff. They're in this pro-inflammatory state. There might be metabolic changes and so on. And we don't tend to think of those as central. And that's very clear in Andreasen's book, The Broken Brain. Right? She never says, maybe something else is going on. She says, oh, these people have got weird thoughts. It must mean their brains have gone wrong. So we're going to image their brains and find out where, and then ultimately we'll have therapies. Why is it that the brain and cognition get this centrality? I think there are two reasons, and they come from two different styles of arguing. I think one is, as a psychologist, I would say, well, the thing that, we are cognitive beings. We have theory of mind. We think about the contents of other people's minds a lot. And they come in saying, I feel miserable. I'm having these terrible thoughts. I'm having these thoughts that keep coming back and I have to ruminate on. And that's what is salient to us because people tell us about their thoughts. So, of course, we focus on that. They don't come in saying, I'm just feeling a bit high in IL-2 today. They don't say that to you. So, of course, we don't attend to that as the kind of the salient feature of what they're doing. I think a more cynical or more critical reading would be to say, neuroscience was really good at getting money out of the NIH for a long time by saying brain imaging is going to fix this, right? And I don't think that degree of cynicism is entirely inappropriate. That there are people whose interests are in saying, if you did just a lot more neuroscience, we'd get to the bottom of this. And I think the NIH in the States in particular has been through a big cycle of that. And of course, there are pharmacological companies that want to sell. They don't want to sell you anti-inflammatories. They want to sell you more expensive specific drugs for depression and anxiety and so on. So there are kind of reasons why that ends up taking a lot of the airtime. Okay, so let's think, I'm going to come back to, by the way, what this suite of things might be all about, but let's do that sort of towards the end. Okay, so that's just questioning a bit whether depression is most usefully seen as a brain disorder, and now I want to ask the question about, is it most usefully seen as a brain disorder? Now, of course, here we rub up against the difference between an informal sense of the word disorder and a more sort of philosophically based sense. This is something that causes terrible suffering, interferes with life, and that the person wishes would go away to allow them to get on with pursuing their goals. So in that sense, informally, clearly it's a disorder, right? So there's one very simple answer to, is depression a disorder? Well, yes, because it does all these things. But lots of other things are disorderly in that sense, like poverty, racism, violence, annoying husbands, and so on. But we don't tend to medicalize those. We don't say, you're poor, that you go and see a doctor about it. Your husband is annoying, go and see a doctor about it. I mean, we understand that these broadly ecological difficulties need to be addressed in a different way. And as Paul rightly said, there's a whole history of thinking in the kind of anti-psychiatry end of the spectrum that really fights the medicalization of depression. And I really very much concur with what Paul says, is that in a way, an integrative evolutionary perspective allows us to understand that there's something good, and those people have got a point, right through to the fact that this is also a condition with neurobiological roots, and that that the medicalization end has, or the neurobiologically reductionist end has a point as well. So, really, what's the case for identifying depression? In particular, I'm thinking about mild to moderate depression and saying yes. The medical frame, something has gone wrong, the medical framing is the right way of thinking about it. And again, the broken brain is extremely clear about this. It's not pulling its punches. It says, other ways of thinking about this have been terrible. This is a better way of thinking about it. This disorder, something is broken within the individual way, is better. Now, one of the central cases that was an argument that I believe its proponents in the late 20th century made, really believing that they were doing a good thing, was the following, that they said, look, if you understand this to be a brain disorder, then you remove blame from the sufferer, right? You remove, people are saying this is not a moral failing. The fact that you're having these terrible experiences is not a moral failing. You don't have to suffer in silence. We shouldn't stigmatize people with mental illness any more than we should stigmatize people with broken legs, because it's not their fault, it's not weakness of character. There really is something medically wrong with them. And also their parents don't have to blame themselves. Were we terrible parents? No, this is a neurobiological dysfunction, and that will kind of lift a whole burden of blame, guilt, and stigma. And unfortunately, I think there's really good evidence by this point that this just doesn't work. It was a genuinely morally motivated claim that if we said this is a brain disorder, this is not just weakness, it will make people feel better about themselves. Now, why doesn't it work? Well. This is a really well-studied phenomenon in social psychology, where people are presented with disorders that are framed either as this is a neurobiological deficit or this is just some life difficulties that the person's having. And if we look at blame, this is from a meta-analysis, if we look at blame, that framing, that neurobiological framing, neither increases nor decreases the blame attributed to the sufferer. If you look at social distancing, to what extent do you want to kind of, not live next door to the person with that condition or not be a co-worker of them, it makes it worse, right? Because if something's in their brain, if their brain's actually broken, this is kind of bad news. If they're just going through a bad patch, you might want to live next door to them. But if they've actually got a broken brain, it makes it worse, right? So this is really unfortunate. They're perceived to be more dangerous if you frame their suffering as having a neurobiological basis. And most importantly, you increase prognostic pessimism amongst sufferers. If you tell me your brain is wrong, your brain has got a dysfunction, they just become more pessimistic about that probability of recovery. This is very important information, because one arm of the sort of moral case for saying, these are medical conditions, these are ordinary medical conditions, was that it would make people reduce stigma and social distancing as a result. And I'm afraid, the evidence seems to be, or the consensus seems to be in this literature, that it's really not clear that that's true. And I think we have to understand that importantly. Now, the other case about, I suppose, taking a more anti-psychiatry hat, the case against this medical framing is that, it's really had a lot of airtime for 40 years, and it's not clear that it's made things better. So when we get framings right, as we did for smallpox, as humanity did for smallpox 70 years ago, or as it did for HIV, enormous progress tends to follow, and the disease incidence is reduced. But in fact, all of the time we've been framing depression more and more as a medical disorder, it's becoming more and more prevalent. Right? So it's not that having the right framing has led us to have the right therapies that has allowed us to reduce the burden of disease. And in fact, this is an obvious point, but antidepressant prescribing has been going up very steadily for decades now, but the incidence and prevalence of disease continues to rise nonetheless, right? So it sort of suggests that we haven't really cracked this nut from this particular point of view. Now, why is that true? Well, it's because, in a way, if one arm of the medical framing was the reduction of blame and guilt, the other arm was that these drugs are great. Remember that the book Listening to Prozac and all of the impact that had 30 years ago. The other kind of sell was the drugs are actually great. They work by fixing your brain. But in fact, we now know, again, a bit sadder but wiser, there tend to be significant differences in meta-analyses of randomized control trials. There are significant differences between antidepressants and placebo, but they're very small. Okay, so in this paper, they're typically done on the Hamilton rating scales, and they make a difference compared to placebo of like a couple of points on those scales. Scales on which the minimum difference thought to be kind of detectable by a clinician is about 7 points, and really the sort of a fairly conservative criteria of what's considered clinically significant is 4 points. So about half of that in meta-analyses. So these are small effects. And there's a genuine debate going on about whether that's because you have a block of non-responders and a block of responders, or whether that's just in fact noise, and the point is these are at best moderately effective drugs. But more importantly, they're only really ever evaluated in these trials over a pretty short time period, 3 to 6 months, okay? But really, this is a chronic problem, and the relevant evaluations you need to be doing over much longer time scales. And there we're starting to have these more ecological long-term studies, and I have to say, it's not looking great, right? So we know that, in fact, people who start to take antidepressants for depression tend to continue, they don't remit, they tend to continue to use them chronically for many, many years. And in some ecological studies, the use of antidepressants relates to a poorer long-term outcome rather than a better one. Now, these studies are super difficult because they're epidemiological studies, and of course, one of the things about taking what they do is they look at depression at time t+1 as a function of various things at time t, including whether you were taking antidepressant drugs. But of course, the people who are taking antidepressant drugs at time t are going to be different in other ways. Their depression is going to be more severe, for one thing. That's why they were prescribed the medication and why they continued them. But nonetheless, they attempt to address these problems by controlling for severity at time t. So you're really saying, once you control for the fact how severe their depression was at time t, of course, that's a huge predictor that they'll have depressive symptoms at t+1. But once you control for that, is there any additional predictive power of having antidepressant drugs at time t? And there is, and it's in the direction of you'll have higher symptoms at time t+1. You can attempt to kind of say, well, look, this is not a genuine trial, and there are various kind of ecological confounds there, but you can throw in as many covariates as you can think of, and fundamentally the conclusion stays the same. So I think these studies are controversial, I know, and there are others in the room who probably know more about it than me, but certainly it's the case that over the short term these drugs are at best moderately effective, and over the long term people are going to continue taking them, and they don't remit totally. Right? They continue to be reliant on them, and they don't entirely solve their life problems. Throwing in note, just from the point of view of discussion points, really, we do know about other things which actually seem to be pretty effective treatments for depression, and one of them is exercise. And now, again, I wonder why we don't talk about that, right? Some of these trials, which again are meta-analyzed, compare exercise to no treatment, some of them exercise to status quo therapy, which often includes pharmacology, and so on. They have various different comparisons. But even when you analyze them on an intention to treat basis, which you have to do because when you prescribe exercise, quite a lot of people don't comply, nonetheless, you get effect sizes which typically seem to be rather larger than for the standard pharmacotherapy. So again, I'm just interested in why people don't talk about this more, because exercise is not obviously about the brain. Obviously, it has an effect on the brain, but it has effects on the whole body and on movement. So it just seems sort of interesting that, again, we don't seem to focus so much on that. Okay, right. Let me get on to perhaps sort of safer ground for me. If we know that the brain differences are subtle, and if we know that the responses to antidepressant drugs are pretty small, what we really do know is that there are hugely strong socio-ecological predictors of depression. I mean, many orders of magnitude stronger in terms of their associations with the clinical disorder. There are many studies I can cite to you here, but we've known for really decades that material hardship, low income, and other kinds of life events are massively strong predictors of depression. In this study, for example, if you had 5 kinds of hardships, which are things like being on food stamps, having your phone disconnected, difficulty paying bills, and so on, and a low income, your probability of depression went up to about 60%, right, prospectively, from sort of 10% in this population at baseline. So that's a huge effect size. We're not, you don't have to worry about statistical significance when you see that something is 6 times more prevalent in one group of people than in others, right? So this just points attention to the fact that the socio-ecological triggers of this disorder are very, very large. This is something from my own research. This is basically the ratio of your income to your monthly outgoings, and this one, the PHQ, is symptoms on a depression scale. As you see, first of all, the higher your income as a multiple of your outgoings, the lower your psychiatric, your depressive symptoms. But the green and the red lines, what they represent, we studied the same people every month for a year, and their incomes obviously went up and down a bit in that year. And the red is in months where their income was a standard deviation worse than usual, their income dropped, and the green is when their income happened to be a bit better that month. A lot of these people have jobs that fluctuate from month to month. And basically what you find is their depressive symptoms get worse in months when their income goes down, and they get better in months when their income comes up. So it's no mystery there's this really tight coupling between socio-ecological circumstances and depressive symptoms. There are now interventional studies, and one of the things you might say is, well, that's all very well, but we can't intervene on people's incomes, can you? Can we? Well, yes, you can. I mean, that's what politics is about, right? It's a way of intervening on people's incomes, and there are taxes, and there are welfare states, and so on. And in fact, by now, there are meta-analyses of randomized controlled trials of cash transfers. What are their effects on depressive symptoms? They go in the direction you might imagine. Now, their effect sizes are small, about 1/10 of a standard deviation. But remember, this is a whole population intervention in which a lot of the people who are getting the cash don't have any depressive symptoms in the first place, right? So you'd expect a small effect size when you're not targeting the 20% with depressive symptoms, but in fact the 100% of the population. But those people are getting their lives made better in other ways, right? So, having your poverty relieved, if it's not improving your depressive symptoms, is still quite a good thing. But nonetheless, you get, these studies are particularly coming from Africa and Latin America. There are rather few studies as yet in high-income countries. But we've known really for years, I mean, going back to the work of Brown and so on back in the 70s, that the socio-ecological drivers of depression are enormously powerful, right? It's really, they showed in these ecological studies back in the day that people who, the onset of depressive episodes was very strongly associated with experiences of threat and loss, bereavements, loss of a job, loss of an important relationship, and so on. And I mean, this is sort of hiding in plain sight, that the effect sizes in these studies were absolutely vast. This is another sort of in-prep study of mine, which is using the European Values Survey, so it's 60,000 participants from 22 countries. What you see is, this is depressive, this symptom cluster. It's a measure that arises from depressive symptoms. I won't go into the details now. And we look at by deciles of income. The red line and the blue line show how the symptoms reduce as you move up the income deciles in whichever country you're in. They're in 22 different countries, these participants. But also, in every decile, if you're lonely, you describe yourself as being lonely, you have fewer social relationships, you're about a standard deviation worse in depressive symptoms, right? In all 22 countries and overall, this is true. This is such a strong pattern that you can almost see it in the naked eye, with the naked eye, which is rare in these kinds of things. So we know that loneliness and hardship are extraordinarily strong drivers of these things. And therefore, just to kind of try and tie all this together, for 40 years we've been wanting to privilege a very individual-based, fairly reductive neurobiological account of these difficulties that's led to a lot of focus on providing certain kinds of therapies, and yet the incidence has continued to go up. And in the meantime, we know actually that the distribution of loneliness, material hardship, and low income and so on would make an enormous difference to the incidence of this disease. So that's where I think the kind of critical psychiatry people do have a point, right? Which is the elephant in the room is actually outside the room. The elephant here is outside in society, not so much. It's not the elephant in the brain, it's the elephant in society. So this is a constellation of experiences. I would say it's a kind of sickness behavior, maybe, and Randy would disagree with that, in which people are fundamentally saving energy, avoiding various kinds of interactions that they perceive could harm them. They're not going out and doing things, taking things on. They're going to a different metabolic state, and they're in this pro-inflammatory state, which is somehow a self-protective, anti-wounding kind of defense mechanism that's highly engaged. Depression is probably heterogeneous, but these are kind of the core of it. And yes, there is individual level cognition. People say, I have these particular ruminations and particular types of pessimism and so on. And those are real, but they may not, in a sense, be kind of causally, there may not be a causal primacy associated with them. And similarly, you have to understand that this state is embedded in this larger social and socio-political matrix. How does the evolutionary perspective help us? So that's my sort of take on depression, is really I want to zoom back from individual neurobiological reductionism and kind of see what's going on in a slightly broader perspective, both broader in terms of the body's systems, but also broader in terms of the socio-ecological context. How does the evolutionary perspective help us? Now, one of the things that I think many people in this room will have experienced is they say, when you say, I take an evolutionary perspective, the people you most naturally think will be your allies, in my case it's people who have a more public health perspective, kind of look at you a bit weird and go, oh God, he's some terrible genetic reductionist. Do you think that means, in evolutionary perspective, that means he's looking for this gene that he can kind of engineer in people that will turn depression off? And it's unfortunate that, the most famous book we always tell people they should read has got gene in the title, right? So, oh my God, he's some sort of weird genetic determinist. So it's unfortunate, right? That evolution is about genes, absolutely, but people think that therefore, to advocate for taking an evolutionary perspective is to advocate for focusing entirely on proximate genetic determination, which is in fact the last thing that we do. I prefer a broader vision of what the evolutionary perspective gives us. And I tend to call it actually an ecological perspective, because then a lot of people you don't scare the horses so much, right? Don't worry, there's plenty of neo-Darwinism in there, but it's sort of, you have to be slightly kind of strategic. And here it's a sort of the kind of crazy uncle of evolutionary psychiatry is Gregory Bateson. He is literally my wife's crazy uncle, in fact. But And he says that the unit of analysis in all this, he's not an orthodox Darwinian by any means. He's not an orthodox anything, anyone who knows the work of Gregory Bateson. But he says the unit of analysis here is the flexible organism in its environment. And I think that's absolutely right. When we talk about an evolutionary perspective, what we say is, yes, there are individual organisms and they have brains and they have immune systems and all the rest of it. But what natural selection has produced them as able to do is have this kind of flexibility that allows them to survive and reproduce across a broad range of ecological conditions. Right? Natural selection leads to this kind of plasticity. But that means that they're really affected by these socio-ecological conditions. That because ultimately they've been shaped to somehow survive despite all kinds of environmental travails and difficulties, it means that they're really pushed around by their socio-ecology. It matters if they have social resources. It matters if they have economic resources. It matters if they have nutritional resources. These really affect the kind of strategies they have to adopt to survive and reproduce. And very often, they have to make the best of a bad job. And this is where Randy's distinction between defenses and dysfunctions is so useful. Lots of the things that happen to you are pretty horrible, fever, pain, but they're making the best of a bad job. They're a defense that's there because your ancestors that had those capacities were able to survive and reproduce in socio-ecologies that were adverse. But that actually means if you want to change the outcome, the ways people have to survive, really changing the socio-ecology becomes a pretty relevant unit of analysis or level of analysis, in my view. So the way I would sort of see this in the depression context is the evolutionary perspective could help us understand that when material and resources, social resources are scarce and when there are threats in the environment, people go into this different energetic state in which their cognition is different, but so a whole load of other things like inflammation and metabolism. And this state allowed them to get by, right? It allowed their ancestors, the existence of this state allowed their ancestors, their lineages to survive in the past. But it's not pretty, right? It's very unpleasant for them, and it's bad for their fitness, it's bad for their health. So the final way that I try and tie all this together, it seems to me that if we're evolutionists, we can think in terms of there being different kinds of interventions that ought to have a big effect on the well-being of organisms, right? There are organismic interventions, like sometimes defenses are just excessive, they're overactive, or they've gone a bit wrong, and there are organismic interventions like anti-inflammatory drugs that we know kind of damp those down and so on. But there are also socio-ecological interventions, right, which affect the inputs into those organisms to change the incidence of those inflammatory states in the first place. And this is somewhat the distinction between clinical medicine and public health. Right? Public health interventions are often you want to change the population distribution of the social determinants, for example, and in clinical medicine you want to treat the individual person who's come to see a doctor and so on. In a way, for me, I think one thing that I get out of the evolutionary perspective is taking a bit more of a public health lens on depression. Okay. Now, you could go further. There are people who want to be anti-science and say, well, the whole idea of psychiatric illness is a social construction, or, as Paul was saying, doctors should never be involved in this. It's essentially a political problem and so on. But, you don't have to go that far to say, if we want to really change the incidence of these experiences, we need to think in a public health or population health way. Interesting intermediate is psychotherapy and counselling, right? Which some people are very keen to say is a clinical medicine intervention, and I would say is actually doing something intermediate between these two. Is often actually allowing people to sort out some of the problems of loneliness, lack of social connection, lack of social and material resources, that's more towards the public health end. But there's a whole spectrum of interventions from public policy at this end to clinical medicine at this end. Just to say, what does that give me? I spend about half of my time these days doing social policy, attempting or failing to do social policy, i.e. trying to persuade politicians to do social policy and them not listening to us. I think I would get probably thrown out of the Common Sense Policy Group if I said this, but between friends I can say it, which is, for me, the evolutionary perspective really led me down this road of thinking the socio-ecological determinants matter. How are you going to make a big difference to the socio-ecological determinants? you're going to make it through politics and policy. That's really, but this group that I'm part of, the Common Sense Policy Group, I think that, you don't have to sign up to the evolutionary perspective to be a member. In fact, I think, many of them would probably think that was a weird way of getting to their particular perspective. But we spend a lot of time writing stuff for politicians trying to lobby for more generous welfare states and other kinds of social policy changes that we think would actually reduce the incidence of mental suffering. Okay, so I'm going to wind towards an end now, Randy, and then we can have time for discussion. What might an evolutionary perspective on depression achieve? I think it promotes a greater whole organism focus. I've always felt that people in the social sciences in particular, when you say the word evolution, they go, oh God, you're terribly reductionist. And I don't see that being true. I think this is an anti-reductionist or a very holistic way of thinking about the world in which the organism is not just a load of bits, but is actually a system that's designed to flexibly respond to its socio-ecology. And of course, it's been shaped by natural selection to do that. And so for me, taking the evolutionary perspective, and Robin, my PhD supervisor, is at the back there, and this is one of your great legacies to me, Robin, for which I'm eternally grateful, is right that you see that an evolutionary perspective, far from being a move towards a kind of biological reductionism, promotes a whole organism focus and promotes a focus on relationships and the socio-ecology and on flexibility. So for me, the evolutionary perspective actually moves us up a layer towards a more public health framing rather than towards a sort of more quote-unquote biological thing. I think that evolutionary arguments can buttress a more socio-ecological approach to thinking about reduction of suffering, where individual neurobiological determinants, though probably real, don't have to be our sole level of analysis. Oh, sorry, no, turned out to be my last point. But let me add then, and I really just want to echo what Paul said in opening. The other thing that the evolutionary perspective has got, which I think is tremendously beneficial here, is it's an intellectually coherent big tent, right? It's a big tent in the sense that if you believe that, as I do, that the social determinants are really important, you don't have to disagree with someone who thinks that, the amygdala is important. The amygdala is important because the social determinants are important. It's just organisms transduce socio-ecological influences through individual biological structures. How could they do otherwise, right? That must be the case. So there's a big tent in which those people can talk to each other and they don't have to be enemies. And I think that's tremendous. But it's better than that because it's a coherent big tent. I mean, there are some big tents which are just, drafty because, the social determinants of health literature, which is one that a big tent that I inhabit quite a lot, is just a nightmare, really, because it's just a load of people who each thinks their individual thing is important. I think equality is important. I think poverty is important. I think, loneliness is important. And they just sort of sit together in this big tent that has no organizing theory to it, except, bad stuff happens to people and it makes them ill, which is true. But our big tent actually has a coherent idea, right? Which is that organisms have been selected to survive and reproduce despite the slings and arrows of the different socio-ecologies they've had to live through, and they have defenses, that may become active in response to those particular threats in patterned and systematic ways. And that is how I think the evolutionary perspective can help us. Big questions for today, and maybe we'll have time to pick them up in discussion, right? Firstly, how do we convey this to clinicians? Because you could sort of say, you could get to the end of everything I've said and says, yeah, everything you said is fine. But really, in 5 minutes, you could have just said, the social determinants are important, and that would have, what does it add that you have to do this great excursus via evolutionary theory and all that? That's a good point. Secondly, does it affect clinical practice or public health practice, taking this evolutionary perspective? I think we could discuss that. Certainly for me, it helps us understand in a deeper way why bereavement, loss, loneliness, poverty would be bad and cause individuals to have different kinds of reactions to them. But does it lead us to come up with new therapies? I don't know. Probably better is allows us to kind of have a more coherent story about why the things that work. But that's a pretty weak sell, right? And then that just allows other people to kind of say, well, it's nice that you've got that. It doesn't actually change what I want to do if I am arguing for a more generous welfare state, in part to reduce the burden of mental suffering. I don't need your evolutionary and ecological perspective. I could have just done that anyway. And I think that's a real point, right? We tend to be enthusiasts, right? We're sort of adherents of this approach, and we like it because we're sort of a bit odd and we find it intellectually coherent and exciting. But lots of people, in my experience, say, well, that's fine, you can do that, but I don't need to. I just want to get on with my thing of, you know, anti-inflammatory drugs or exercise therapy or public health or whatever. So I think live questions are, you know, how can we present this approach as a resource to people, to bring people together, to have a more integrative perspective on this, and how does it need to change what we do? It's fine, small groups of us getting together and finding it intellectually stimulating to see how it all fits together, but does it actually change anything? I think on that note, I'll stop, Mandy, because maybe it's a segue to discussion.